Etiology. Etiology of rheumatic fever. Beta hemolytic streptococcus of group A. It is the main causative agent of acute rheumatic fever, and this connection is confirmed by frequent incidence of acute rheumatic fever following streptococcal infection, for example, sore throat, increased antibody titers to various antigens and enzymes of the streptococcus in the blood of rheumatic patients, successful prophylaxis of acute rheumatic fever by antibacterial drugs. Pathogenesis of rheumatic fever. Pathogenesis of acute rheumatic fever is complicated and includes three important phases. The first, acute phase, mainly oral pharyngeal infection by the group A streptococcus. The next phase, toxic effect of streptococcal extracellular products on the host connective tissues. And the third, an abnormal or dysfunctional immune response to one or more somatic and or extracellular antigens produced by all or perhaps only by some group A streptococci. This is example of streptococcal pharyngitis in 16-year-old patient caused by Streptococcus group A. So we continue about pathogenesis. At the present time, the development of the disease is described as follows. Most persons affected by Streptococcus develop stable immunity, and this immunity does not develop in 2 or 3% of the affected subjects due to weakness of their defense mechanisms, and they become sensitized by the Streptococcus antigen. In these conditions, the infection re-enters the body to cause a hyperergic response in connective tissue, and clinical signs of the disease thus develop. So it means that acute rheumatic fever will develop in predisposed persons with weakness of immunity, of immune system. Autoimmune processes are very important in the onset of acute rheumatic fever. The affected connective tissue acquires antigenic properties. Autoantigens or secondary antigens cause formation of aggressive autoantibodies. They affect not only the connective tissue that has already been affected by the primary antigen, but also intact tissue to aggravate the pathology. Reinfection, cooling, and overstrain promote formation of new autoantigens and autoantibodies to strengthen the pathological reaction of the upset immunity and to provide conditions for the recurring progressive course of the disease. According to pathological anatomy, there are 4 phases of derangement of connective tissue. So for your classes, you must revise your knowledge from pathanatomy about characteristic of each phase. So the phases are mucoid swelling, fibrinoid changes, granulomatosis, and sclerosis. It is very important to know about these phases in order to understand the outcome of acute rheumatic fever. Outcomes of rheumatic fever are acquired valve defects, for example, mitral stenosis or mitral insufficiency. So, and in order to understand the mechanism of formation of these acquired valve defects, you must know characteristic of these 4 phases of derangement of connective tissue. And the last about pathophysiology and about the phenomenon of molecular mimicry. Molecular mimicry plays a very important role in pathogenesis of acute rheumatic fever. So molecular mimicry accounts for the tissue injury that occurs in rheumatic fever. Both the humoral and cellular host defenses of genetically vulnerable hosts are involved. In this process, the patient's immune response, both B and T cell mediated, are unable to distinguish between the invading microbe and certain host tissues. And the resultant inflammation may persist well beyond the acute infection and produces the manifestations of rheumatic fever. So once again, in pathogenesis play a role developing, producing of autoantibodies and molecular mimicry, 2 phenomena. Epidemiology of acute rheumatic fever. Acute rheumatic fever is most common among children aged from 5 to 15 years. It is relatively rare in infants and uncommon in preschool-aged children. Acute rheumatic fever occurs in young adults, but the incidence of first episode of acute rheumatic fever falls steadily after adolescence and is rare after age 35 years. The lower rate of acute rheumatic fever in adults may represent a decreased risk of streptococcal pharyngitis in this cohort. Recurrent episodes with their predisposition to cause or exacerbate valvular damage occur until middle age of these patients. This picture illustrates the pathogenesis and pathophysiology of acute rheumatic fever. So the first phase, the streptococcus adhesion and invasion in pharyngeal epithelium, then antigen processing and presentation to B and C cells. The next will be generation of cross-reactivated B and T cells and production of cross-reactive antibodies, and then damage, tissue damage and organ-specific manifestations. So acute rheumatic fever has 4 target organs: heart, brain, joints, and skin. So it influences the tissue, connective tissue of heart, brain, joints, and skin. Classification of acute rheumatic fever. Clinical variants. It may be acute rheumatic fever and recurrent acute rheumatic fever. By clinical manifestations, acute rheumatic fever is classified into basic clinical manifestations such as carditis, arthritis, chorea, rheumatic nodules, and erythema marginatum, and additional clinical manifestations such as arthralgia, polycerasitis, and abdominal syndrome. According to the degree of activity, acute rheumatic fever is divided into minimal activity, moderate activity, and maximal or high activity. According to clinical outcome, acute rheumatic fever is classified into recovery and chronic rheumatic disease of heart without heart valvular defect or with heart valvular defect. and according to the presence of chronic heart failure, acute rheumatic fever is classified into functional classes according to New York Heart Association, or degree of chronic heart insufficiency, and according to the stages of chronic heart failure. Clinical picture of acute rheumatic fever. So acute rheumatic fever affects children, adolescents, and young adults. This disease develops in 2-6 weeks after acute streptococcal pharyngeal infection. So it means that when you are performing questioning of the patient, you must carefully get information about his past medical history. The typical onset of the disease is subfebrile, less frequently febrile temperature, weakness, sweating during 1 to 3 weeks. Simultaneously or several days later, patient feels pain in the joints, palpitation and intermissions in the work of the heart, the feeling of heaviness or pain in the heart, and dyspnoea. So, rheumatic fever symptoms, which result from inflammation in the heart, joints, skin, and central nervous system, also may be fever, painful and tender joints, most often knees, ankles, elbows, and wrist, pain in one joint, which migrate to another joint, so migratory character of pain, red, hot, or swollen joints, small painless bumps, nodules beneath the skin, chest pain, and hot murmurs. Fatigue, flat or slightly raised painless rash with a reached age, erythema marginatum, jerky, uncontrollable body movements, most often in the hands, feet, and face, outbursts of unusual behavior such as crying or inappropriate laughing that accompanies Sydenham chorea. Sydenham's chorea, a central nervous system disease, often of insidious onset but of finite duration, characterized by involuntary, purposeless, non-repetitive movements and subsiding without neurological residue. It is very important idea that acute rheumatic fever will subside without any neurological residue. Sydenham's chorea occurs in fewer than 10% of patients with rheumatic fever. This is due to either rheumatic vasculitis attended by small hemorrhages or thrombosis of cerebral vessels, or inflammation of the brain and the spinal cord. Children, as a rule, patients younger than 15 years, would develop encephalitis with predominant localization in the subcortical nodes, so-called chorea minor. It is manifested by emotional lability and hyperkinesia. Hyperkinesia means abnormal movements of the extremities, trunk, and facial muscles. The latent period between the onset of the initiating streptococcal infection and the onset of Sydenham's chorea may be as long as several months. Many patients who appear to have only chorea may present several decades later with evidence of typical rheumatic valvular disease. There is no definitive laboratory test for establishing a diagnosis of Sydenham's chorea, and the diagnosis is one of exclusion. So the characteristic of rheumatic polyarthritis. Migratory polyarthritis is present in as many as 75%, so it is the most common symptom of acute rheumatic fever. Migratory polyarthritis is characterized clinically by very important symptoms: symmetrical arthritis of large joints such as ankles, wrists, knees, and elbows. It usually does not affect the small joints of the hand or feet and seldom involves the hip joints. The next very important characteristic is migrating character of pain. Pain disappears in one joint and develops in another joint. Extremely painful, hyperemic, and increased temperature, skin temperature of joints may be observed. Joints become swollen, sometimes with effusion, but polyarthritis is usually benign, so all clinical changes are completely reversible. It is very important that all changes are completely reversible. It means that acute rheumatic fever we may differ from rheumatoid polyarthritis, which leads to functional inability of joints. The next, rheumatic carditis. Rheumatic carditis is the most important aspect of this disease as it has major long-term implications. Rheumatic carditis includes endocarditis, myocarditis, and pericarditis. So it means inflammation of endocardium, inflammation of myocardium, and inflammation of pericardium. The diagnosis of carditis requires the finding of new cardiac murmurs, cardiomegaly, pericarditis, and congestive heart failure. So rheumatic myocarditis is characterized by dyspnoea, the feeling of heaviness and pain in the heart, palpitation, and intermissions in the heart work. Percussion will detect enlargement of the heart, and auscultation may reveal decreased heart sounds, especially the first heart sound, gallop rhythm, and a soft systolic murmur at the apex beat. It is associated with relative mitral valve insufficiency, so incompetence of the valve or affection of the papillary muscles. The pulse of these patients is small and soft, may be tachycardia and arrhythmia. Blood arterial pressure is usually decreased, and on recording of ACG we may detect a prolonged PR or PQ interval. It means the first degree of AV block. Circulatory insufficiency rapidly develops in grave diffuse myocarditis, and myocardial cardiosclerosis develops in benign outcome of the disease. Rheumatic endocarditis. Rheumatic myocarditis usually concurs with rheumatic endocarditis, and it is called rheumacarditis. The mitral valve is mostly affected in endocarditis. Next in incidence follows the aortic valve. The tricuspid valve is affected still less frequently. Early endocarditis are not pronounced. Symptoms of myocarditis prevail. At early stages of endocarditis, systolic murmurs become coarser than in myocarditis. The murmur becomes louder after exercise. In some cases it becomes musical. Diastolic murmur may be heard as well. It is probably explained by deposition of thrombotic mass in the valve cusps, which produces turbulence in the blood flow as it passes from the atrium to the ventricle. These thrombotic deposits on the valves can leave their seat and become the cause of embolism or infarctions in various organs, for example, kidneys, spleen. If early attacks of rheumatic endocarditis are treated timely, development of the valvular heart disease may be prevented. The introduction of echocardiography has assisted the identification of subtle abnormalities of the mitral valve, and this may be present in an additional 20% of patients who don't have an audible heart murmur. The mitral valve is involved most frequently, followed by the aortic valve. However, isolated aortic valve disease as a consequence of acute rheumatic fever is quite rare. In patients with aortic valve disease due to rheumatic fever, the mitral valve is almost always simultaneously affected. Rheumatic pericarditis is maybe dry, fibrinosus or exudative. Rheumatic pericarditis may present with chest pain, dyspnea, fever, pericardial rupture friction murmur, ACG changes or radiological changes, or may be discovered incidentally in the course of a systemic illness. Dull or sharp precordial or substernal pain may radiate to the neck, trapezius ridge, especially the left, or shoulders. Pain varies from mild to severe and is usually aggravated by thoracic motion, cough, and respiration. It may be relieved by sitting up and leaning forward. Tachypnoea and non-productive cough may be present. Fever, chills, and weakness also are very common for rheumatic pericarditis. The most important physical finding is a triphasic or asystolic and diastolic precordial friction rupture. However, it is often intermittent and may be present only in systole or less frequently only in diastole. Considerable pericardial fluid may muffle heart sounds, increase the area of absolute cardiac dullness, and change the size and shape of the cardiac dullness. It will have trapezium shape. So, how to make a diagnosis of acute rheumatic fever? The diagnosis of acute rheumatic fever is made according to criteria, specific criteria, which are called Jones criteria. Jones is the last name of researcher, physician who has who formulated this criteria. According to Jones criteria, there are major criteria and minor criteria, and we must estimate major and minor criteria, and we must have an evidence of streptococcal infection, positive culture of streptococcus, or elevated and rising anti-streptolizin O or DNase streptococcus. So major criteria, Jones criteria, are polyarthritis, a temporary migrating inflammation of the large joints, carditis, myocarditis, endocarditis, or pericarditis, which may be accompanied by congestive heart failure. The next, subcutaneous nodules and erythema marginatum and Sydenham's Harry. So 1, 2, 3, 4, 5. 5 major criteria. This is illustration of erythema marginatum, ring-like rash. Minor criteria are fever, arthralgia. Arthralgia means joint pain without swelling. The next criteria, raised erythrocyte sedimentation rate or C-reactive protein. Next criteria, leukocytosis means increased WBCs. ACG showing features of heart block, the first degree of AV block is detected by prolonged PR or PQ interval, or echocardiography, which may detect mitral valve insufficiency and mitral regurgitation. And the last minor criteria, previous episode of rheumatic fever or inactive heart disease. And you must remember the diagnostic rule. So we must assess 2 major criteria or 1 major and 2 minor criteria if supported by evidence of an streptococcal infection. We may prove streptococcal infection by increased titer of anti-streptococcal antibodies, positive throat culture, or recent scarlet fever. So, some words about principles of treatment of acute rheumatic fever. Treatment of acute rheumatic fever includes etiologic antibacterial therapy, pathogenetic anti-inflammatory therapy, and symptomatic therapy. So for etiologic therapy we use antibiotics, taking into account the sensitivity of streptococcus. Pathogenetic or anti-inflammatory therapy includes applying of glucocorticosteroids and or non-steroid anti-inflammatory drugs. The duration of therapy is from 1 month up to 5 months. And symptomatic therapy includes therapy of chronic heart failure. So we may use such drugs as diuretics, beta blockers, angiotensin inhibitors, and cardiac glycosides. Cause of rheumatism or acute rheumatic fever. Acute rheumatic process continues for 3 to 6 months. In some cases it may be longer, depending on the strength of clinical symptoms and the character of the disease course. 3 degrees of rheumatic activity are distinguished: maximum, with continuous relapses, moderately active or subacute, and with minimal activity. If the clinical symptoms of the disease are absent and no signs of active rheumatism are revealed by laboratory testing, acute rheumatic fever is considered inactive. Acute rheumatic fever is characterized by relapses or recurring attacks which are provoked by infection, overcooling, and physical overstaying. The clinical symptoms of relapses resemble the primary attack of the disease. but the signs of affection of the joints or serous membranes are less pronounced. Symptoms of heart affection will prevail. Prognosis of acute rheumatic fever depends on the severity of the initial carditis. Patients with severe carditis during the acute episode may be left with residual heart disease that is often worsened by the rheumatic recurrences to which they are particularly susceptible. Murmurs eventually disappear in about half of patients whose acute episodes were manifested by mild carditis without major cardiac enlargement or decompensation. Healing of rheumatic valvulitis may cause fibrous thickening and adhesions, resulting in the most serious complication of rheumatic fever, such as valvular stenosis and or regurgitation. All other manifestations of the acute rheumatic fever subside without residual effects. So that's all about rheumatic fever, acute rheumatic fever, and the second part of our lecture we will focus on acquired heart defects. So acquired heart defects may be divided into congressional and acquired. Today we are going to talk about acquired heart defects. These defects are characterized by damage of the valvular apparatus of the heart and the main vessels and arise as a result of heart disease after birth. Among these diseases, acute rheumatic fever is more important, less atherosclerosis, syphilis, bacterial endocarditis, brucellosis, and trauma. Acquired heart diseases are chronic diseases. In rare cases, for example, when valve flaps are destroyed due to ulcerative endocarditis, actually occur. So, the most common forms of heart valve disease affect the mitral and aortic valves, causing left heart failure and pulmonary congestion. The valves may fail to open fully, it is called stenosis, or to close. It causes regurgitation or incompetence of the valve. Both stenosis and regurgitation can coexist. The effects of both types of lesion are hemodynamic with major implications for cardiac function. So for the first we will talk about mitral stenosis. Mitral stenosis means diminishing of the area of mitral ostium. Mitral stenosis has two stages, compensation stage and decompensation stage. In compensation stage of the disease, the area of mitral ostium is significantly less than normal. Normal area is from 4 to 6 square centimeters. That leads to left atrium repletion with blood. This blood had no time to move to the left ventricle, and there is also blood derived from pulmonary veins. It will result in left atrium hypertrophy. In decompensation stage of the disease, left atrium contractility is decreased, pressure within it increases. That leads to the pressure rise within the pulmonary veins and pulmonary capillaries. The latter leads to switching on Kitaev's reflex, which means the pressure rise within the pulmonary veins ostia causes the narrowing of the pulmonary arterioles. And when pressure rising within the pulmonary artery and further overload and hypertrophy of the right ventricle develops. The left ventricle diminishes at the rate because it performs the less work. So this picture illustrates hemodynamic abnormalities of compensation and decompensation stage of mitral stenosis, and as a consequence, appearance of symptoms of mitral stenosis. So pulmonary congestion and elevated pulmonary venous pressure will lead to pulmonary congestion. So pulmonary congestion means edema. That is why a patient will feel dyspnea. So the main symptom of mitral stenosis, the main complaint, will be dyspnea. After elevating of wedge pressure and hypertrophy and dilatation of right ventricle, patients may have right ventricle heart failure. It will manifest as leg edema, ascites, enlargement of liver. So once again, clinical manifestations. Characteristic complaints and mitral stenosis appear on development of congestive changes in pulmonary circulation. Patients notice only a gradual decline in exercise tolerance and dyspnea. Patients may have cough and hemoptysis. Hemoptysis will develop due to the damage of pulmonary capillaries by high pulmonary pressure. They also may have palpitation and arrhythmia and sometimes chest pain. Episodes of acute pulmonary edema occur as the cross-sectional area of the valve diminishing, and the patient may have episodes of acute dyspnea and orthopnea and paroxysmal nocturnal dyspnea. The next very important clinical presentation of mitral stenosis is systemic embolism. Systemic embolism is common from thrombi in the large left atrium, especially in the presence of atrial fibrillation. The common sites for embolism are cerebral, mesenteric, renal, and limb arteries. If disease develops in childhood, physical developmental lag, so-called infantility or mitral nanism, may be observed. Jugular venous pulsation becomes obvious only when right heart failure appears. On precordium inspection, the cardiac beat is frequently apparent due to the right ventricle hypertrophy and dilatation, so-called right ventricle heave. Apex beat is not strengthened. Diastolic thrill, so-called diastolic cat's paw, may be detected on apex beat palpation. 2/3 of the patients are female. They may have a malar flush, so-called facies mitralis. So this symptom is called facies mitralis, and acrocyanosis may be detected. There may be signs of weight loss or peripheral edema in case of right ventricle heart failure. On heart percussion, the relative cardiac dullness, enlargement to the right and upwards, owing to left atrium and right ventricle hypertrophy, may be detected. The heart acquires mitral configuration with absence of cardiac waste. In this valve disease, the left borders of relative and superficial dullness may merge. Auscultation picture. Since a little amount of blood gets into left ventricle, and it contracts fast. So S1 at the apex beat becomes loud and flapping, and hereafter S2 the additional hard sound appears, mitral opening snap. Flapping S1, S2 and opening snap create the typical of mitral stenosis melody, which is called quail rhythm. And also we may hear rumbling diastolic murmur at the apex beat, because there is narrowing down blood flow from the left atrium to the left ventricle on diastole. That is why we will hear diastolic murmur. This murmur may occur in the very beginning of diastole, so to be protodiastolic, because due to pressure gradient in atrium and ventricle in the blood flow velocity will be high at the diastole beginning, and however murmur appears only at the end of diastole, before the very systole, so it will be presystolic murmur, which appears in blood flow acceleration at the end of diastole due to atrial contraction. So it means that diastolic murmur in case of mitral stenosis may have two extenuations, at the beginning of diastole and at the end of diastole, like in this picture. So this picture illustrates the auscultative picture of mitral stenosis. Flapping and extenuating S1, then S2, then opening snap, and diastolic murmur with presystolic extenuation. There may be unequal pulse on both arms in mitral stenosis. In significant left atrium hypertrophy, the left clavicular artery is compressed and pulse filling on the left arm is decreased. This will be the cause of pulsus deferens, so different pulse on the left and the arm wrist. In decreased filling of the left ventricle and diminished cardiac stroke volume, the pulse becomes small. It is called pulsus parvus. Mitral stenosis is frequently complicated by atrial fibrillation. In this case, pulse becomes irregular. So it means that mitral stenosis may be characterized by unequal parvus and irregular pulsus with presence of pulsus deferens. Blood pressure is usually normal. Sometimes the systolic pressure is slightly decreased and diastolic may be increased. ACG changes in case of mitral stenosis connected with left atrium and hypertrophy and right ventricle hypertrophy. This record represents left atrium hypertrophy. Left atrium hypertrophy is characterized by increased duration of P wave, particularly in the first and the second standard lead, and P wave becomes B-feed, so it has two tops, like in this example, B-feed, P wave. This B-feed and prolonged P wave is called P mitrale. So left atrium hypertrophy is characterized by presence of P mitrale. P mitrale means prolonged duration and B-feed P wave. Right ventricle hypertrophy is presented on this ACG record. It is characterized by very high air waves in V1, V2 chest leads, so-called right chest leads, and deep S wave. The diagnosis of mitral stenosis should be confirmed by echocardiography, which will show the immobility of the mitral valve cusps and may show atrial thrombus. Doppler echocardiography allows to estimate the left atrioventricular ostium area. Next, defect mitral incompetence. Mitral incompetence means incomplete closure. So hemodynamics in mitral incompetence is characterized by partial blood regurgitation into the left atrium in case of incomplete closure of mitral valve leaflets. The atrium filling increases since the regurgitated part of blood adds to usual blood volume arrived from pulmonary veins. Pressure in the left atrium increases, it dilates and hypertrophies. During diastole, greater than normal blood volume flows from overfilled left atrium into the left ventricle. That leads to the left ventricle overfilling and dilatation. Left ventricle should work with overload, due to which its hypertrophy develops. In decrease of hypertrophied left atrium contractile capacity, congestive phenomena in left circulation circle appear and pressurizes that demands overwork of right ventricle. So in time in mitral incompetence, the right ventricle hypertrophy also may develop in decompensation stage. This picture illustrates hemodynamic abnormalities of mitral incompetence. So once again, mitral incompetence is incomplete closure of mitral valve during systole of left ventricle. That is why some portion of blood during systole of left ventricle will return back from left ventricle to left atrium, and the volume of the blood in left atrium will increase because there is two portions of blood from pulmonary veins and from left ventricle. That is why left atrium dilatation and left atrium hypertrophy develops, and after this develops elevation of pulmonary veins pressure and pulmonary congestion. The most of patients with minor or moderate incompetence protractedly have no symptoms and signs and may look healthy. Such symptoms as dyspnea, palpitation, and cyanosis appear only in congestion phenomena in pulmonary circulation development. On general inspection, on precordium palpation, apex beat displacement to the left and sometimes downward may be detected. Apex beat becomes diffuse, enhanced, and resistive, so-called left ventricle heave, and it is characterized the left ventricle hypertrophy. So once again, due to development of left ventricle hypertrophy, apex beat becomes diffuse, enhanced, and resistive. On the heart percussion, its dullness enlargement to the left and upwards due to left atrium and left ventricle dilatation is revealed. The heart acquires mitral II configuration with smooth cardiac waist. On right ventricle hypertrophy, cardiac dullness also shift to the right. Auscultation picture of mitral incompetence. Mitral incompetence is characterized by diminished S1, systolic murmur appearance, and exonation of S2 at the pulmonary artery. In severe valve disease, murmur of considerable intensity is registered at the left axilla. Systolic murmur is directly connected with defect formed between valve leaflets and reverse blood flow regurgitation through this chink. So this picture illustrates the auscultation picture of mitral incompetence. When the mitral valve fails to close fully in systole, blood regurgitates from left ventricle to left atrium, causing a murmur, systolic murmur, which is registered between S1 and S2. S1 is diminished because the valve component of S1 is disturbed. An apical S3, pathological S3, reflects the volume overload on the left ventricle. So it means that sometimes in the case of mitral incompetence we can hear gallop rhythm, pathological gallop rhythm. Gallop rhythm means that instead of normal 2 heart sounds, we will hear 3 heart sounds. So how to confirm the diagnosis? The diagnosis may be confirmed by chest X-ray. Chest X-ray shows enlargement of left ventricle and atrium, detected by heart shadow enlargement to the left, upwards and backwards. On pressurizing in the pulmonary circle, enlargement of pulmonary arch and sometimes calcification of mitral valve are detected. ACG may help us. ACG will detect left ventricle and left atrium hypertrophy and atrial fibrillation as an outcome of mitral incompetence. Echocardiography shows the position of valve leaflets at closure, and color flow Doppler may show the regurgitant jet. So this is ACG of left ventricle hypertrophy. Left ventricle hypertrophy is characterized by high airway in left chest leads V6 and V5 and deep S in right chest leads V1, V2. And we can calculate the sum of amplitude SV1 and RV5, so-called Sokolov's index. If it is more than 35, it means that patient have left ventricle hypertrophy. X-ray of the chest of the patient with combined heart defect, the combination coexisting of mitral stenosis and mitral incompetence. So we see the enlargement of the heart shadow with enlargement of left ventricle arch upwards and to the left, and shifting of the arch of left ventricle also to the left, and symptoms of pulmonary congestion. Color Doppler study of mitral incompetence. So this is left ventricle, this is left atrium, and this is colored jet, is a jet of regurgitation, of backflow from left ventricle to left atrium. Next defect, aortic incompetence. Aortic incompetence is a valve disease in which the semilunar cusps close incompletely the aortic orifice, and during diastole blood regurgitates from aorta into left ventricle. Aortic regurgitation occurs in the aortic valve ring dilates as a result of dissecting aneurysm, ankylosing spondylitis or syphilis, for example, or if the valve cusps degenerated, such as after rheumatic fever, or atherosclerotic lesion, or bacterial endocarditis. So this is the picture illustrating aortic incompetence, which is characterized by regurgitation or backflow from aorta to left ventricle in diastole. So it causes left ventricle overfilling and stretching on diastole. During systole, left ventricle contracts with greater force to eject into aorta increased stroke volume. Left ventricle overwork leads to the hypertrophy and increase of systolic blood volume in aorta causes its dilatation. Sharp fluctuation of blood pressure within aorta during systole and diastole is characteristic for aortic incompetence. Increased as compared with normal blood volume within aorta during systole cause increase of systolic blood pressure, and as a part of blood volume regurgitates into ventricle during diastole, diastolic pressure rapidly declines. So this is a very particular common characteristic of hemodynamic abnormalities in case of aortic incompetence. Very high systolic pressure and low diastolic pressure. Clinical manifestation. Clinical symptoms often occur later because this valve disease is compensated by overwork of powerful left ventricle. In time, symptoms of heart failure, dyspnea, palpitation, weakness, and so on gradually appear. The most common symptom of aortic incompetence is angina-like pains in the precordium. They are caused by coronary insufficiency due to severe myocardial hypertrophy and worsening of coronary arteries blood supply upon low diastolic pressure within aorta. So once again, I emphasize that in case of aortic incompetence, diastolic pressure is very low, and that is why coronary arteries blood supply decreases and patient will have angina-like pains. The next very important symptom of aortic incompetence is dizziness. Dizziness is observed owing to worsened cerebral blood supply, also connected with low diastolic pressure. General examination. On general examination, we may detect paler skin color caused by small blood filling of arterial system during diastole. Also, we may detect peripheral arteries pulsation, such symptoms as carotid dance symptom, Musse symptom, Quinn's sign, and so on. So revise your knowledge about these symptoms from previous semester. We have talked about these symptoms. On precordium inspection, increased and displaced downward and to the left apex beat is almost always obvious. Sometimes, along with high apex beat, a light retraction in the area of adjacent intercostal space may be noted. On palpation of apex beat is detected in 6, sometimes even in 7 intercostal space, laterally from the left midclavicular line. It will be diffuse, lifted, increased, dome-like, which witness a big enlargement of left ventricle. So these are the symptoms of left ventricle hypertrophy. And in this case, apex beat is called left ventricle heave. On heart percussion, the displacement of the left of cardiac dullness is detected, and the heart acquires aortic configuration with accentuated cardiac waste. So this is aortic heart configuration. Left ventricle arch is shifted to the left and downwards, and the heart waist is accentuated. Auscultation picture of aortic incompetence. On auscultation, we may detect diminished S1 at the apex beat due to severe left ventricle hypertrophy and because of absence of period of closed valves. S2 is also diminished because of incomplete closure of aortic valve, but for example, in syphilitic and atherosclerotic lesions of aorta, S2 may be clear enough, maybe even enhanced. And the most typical auscultative symptom of aortic incompetence is diastolic murmur, which is listened at the aorta, and in additional Botkin-Airbus point, which is best heard by sitting the patient upright, leaning forward in full expiration. Diastolic murmur in aortic regurgitation is located in the second, fourth, left interspaces and radiates to the apex beat to the right sternal body. The murmur is high-pitched, blowing in quality, may be mistaken for breath sounds, and once again it is better heard with the patient sitting, leaning forward, with breath held in exhalation. It is usually soft, blowing, protodiastolic murmur, weakening to the end of diastole as blood pressure decreasing in aorta and blood flow slowing. In aortic incompetence, pulse becomes fast, high, and big. In Latin it is called pulsus celer, altus, and magnus. As big pulse pressure means the difference between systolic and diastolic pressure. So, peculiar to this valve disease and increased stroke volume, input into aorta during systole influence the character of pulse. Blood pressure is always changed. Systolic pressure is increased, diastolic pressure decreased, and pulse pressure is very high. In order to confirm our diagnosis, we need chest X-ray. Chest X-ray shows left ventricle enlargement with attenuated cardiac waste, aorta dilatation, and its increased pulsation. So this is the X-ray of the chest of typical aortic configuration of the heart, with shifted to the left of the left ventricle and attenuated of the waist of the heart. We also may perform ACG. ACG will show the symptoms of left ventricle hypertrophy. Echocardiogram show left ventricle enlargement. Aortography or color flow Doppler will show the regurgitation jet, like in this illustration. So this is left ventricle, this is aorta, and this color jet is the jet of regurgitation, of backflow from aorta to left ventricle. And the last, aortic stenosis, narrowing of aortic ostium. So this picture illustrates the pathogenesis and hemodynamic abnormalities of aortic stenosis and obstruction of left ventricle outflow. This obstruction leads to left ventricle, to increasing of left ventricle pressure, hypertrophy and dilatation of left ventricle, a little narrowing of aortic ostium does not cause significant circulation alteration. If the degree of stenosis is high, during systole the left ventricle empties incompletely, as all blood volume has no time to pass across narrow ostium into aorta. On diastole, normal blood volume from the left atrium adds to this residual blood portion that leads to left ventricle overfilling, pressure rising within it. This abnormality of intracardiac hemodynamics is compensated by left ventricle overwork and causes its hypertrophy. Aortic stenosis for a long time may be in compensated stage of disease and does not cause some unpleasant subjective sensation even in high physical exertion. Insignificant narrowing of aortic ostium, insufficient blood ejection into arterial system leads to blood supply disturbance of hypertrophied myocardium, in connection with which chest pain at the precordium, similia, angina pectoris appear. In case of cerebral blood supply disturbance, dizziness, headache, inclination to syncope occur. These phenomena are frequently occurred on physical and emotional exertion. So, aortic stenosis leads to left ventricle hypertrophy and relative left ventricle ischemia. So, patients may have the symptoms of angina pectoris, infarction, left ventricle failure, or different types of ventricle arrhythmias. Ventricle fibrillation is a common cause of sudden death of these patients. Calcification around the valve may extend into the conducting tissue, causing heart block and syncope. General inspection of the patients. On patient inspection, skin paleness caused by small blood filling of arterial system is marked. Apex beat is shifted to the left, rarely downward. It is high, diffuse, and resistive, so-called left ventricle heave. On palpation of precordium, systolic thrill or systolic cat's paw at the right second intercostal space close to the sternum is disclosed. On heart percussion, the displacement of relative dullness bodies to the left and aortic heart configuration with attenuated cardiac waste caused by left ventricle hypertrophy are detected. Pulse. Since the presence of obstacle blood passes into aorta slowly and in less volume, pulse becomes small, slow, and rare. In Latin it is called pulsus parvus, tardus, and rarus. Systolic pressure usually decreases and diastolic stays normal or increases. So pulse pressure becomes decreased in case of aortic stenosis. Auscultation picture. On the heart auscultation at the apex beat S1 is diminished due to left ventricle hypertrophy and overfilling. At the aorta, in the second intercostal space at the right edge of the sternum, S2 is diminished in case of adherent valve cusp's immobility. It may not be heard. And the most important symptom is rough systolic murmur connected with blood flow across the narrow ostium at the aorta. This systolic murmur radiates along blood flow direction to the carotids, and sometimes it may be heard at the intrascapular area. So this picture illustrates auscultation in case of aortic stenosis, where you can hear mid-systolic murmur in aortic stenosis in the second right intercostal space, which radiates to the neck and down to the left sternal border, maybe even to the apex and interscapular region. This murmur is best heard with the patient sitting and leaning forward. Instrumental methods which can confirm aortic stenosis. ACG will detect the symptoms of left ventricle hypertrophy, sometimes symptoms of coronary insufficiency. Echocardiography confirms the diagnosis by showing thickening and calcified valve cusps. Doppler color echocardiography or cardiac catheterization, or both of them, establish the severity of the stenosis. And Doppler color echocardiography is extremely valuable in following the course of the disease in individual patients. Ultrasound has removed the need for repeated cardiac catheterization. The peak aortic pressure gradient can be calculated, and it correlates well with the degree of severity of stenosis. Other formula may be used to measure the aortic valve ostium area. So that's all for today.